all. This is Dr. Mobeen Sayed from drbeen.com. Welcome to one more show. So, the discussion today is about the respiratory syncytial virus, RSV. And the cases have been reported to be increasing, even to the statements, for example, in JAMA, I'll show it to you, or JAMA, where it says this is children's COVID or this is our COVID compared to the pediatrician saying that. So I wanted to make sure that one, we are, excuse me, we are aware of the signs and symptoms. We are aware of what management options are available, and a little more about the virus itself as well. So let's start a discussion. So this is drbeen.com. In the description, there is a link for access to drbeen.com with a one-time lesser than $100 fee. This is one of the links, and I wanted to read this out first so that we are all aware of what is the management. Eventually, that is what is going to matter a lot. So usually for healthy children, management is supportive. However, for premature children or children with the chronic diseases because of prematurity or congenital cardiac diseases, etc., or immunocompromised adults, there may be a need for monoclonal antibodies. So here, in the case of the RSV, there is a monoclonal antibody called palivizumab, which has been used for, I think, 8-9 years or more, but not for everyone. And then if you see here, there are certain vaccines that are now being tested. There is actually no vaccine because the vaccines have been failing. Not only these have been failing, but the original vaccines that were developed with the inactivated virus caused increased severity, which then caused 85% of the children with the vaccination to end up in the hospital compared to 5% of the children with the actual natural infection. And not only that, 2 vaccinated children died as well. So they quickly stopped that vaccination. So there is no vaccination. However, there are many new vaccines that are being developed, and there are vaccines that are being developed for pregnant women as well. And I'll explain why. In Europe, so if you see this green part here, in Europe, regulators in the European Union recently approved a long-acting single-dose monoclonal antibody called nirsevimab, which is Beyfortus, for use among all infants, not just those at high risk. The problem is that palivizumab, I'll have to read it. That drug has to be given every month for at least 5 months. So palivizumab. Okay, so with this, let's start. This is the pediatric guidelines by the American Academy of Pediatrics. I want to read that guideline to us so that we know that which children need to have the drugs. And then there are some more links related to this. So with this, now let's quickly look at, my apologies, I have to go through these window switches because my software has changed. Okay, so respiratory syncytial virus or syncytial virus. Quick knowledge about this virus. It is an enveloped virus, just like actually SARS-CoV-2, which has an envelope as well. It is called orthopneumovirus, pneumo for causing pneumonia or respiratory viruses. It is a negative sense single-stranded RNA virus. The SARS-CoV-2 is a positive sense single-stranded RNA virus. So this one is a negative sense. It has a couple of important proteins on its surface that allow it to attach to our cells and then enter them. One is called the fusion protein, or F protein, just like a spike. The other one is called attachment protein or glycoprotein or G protein. The G protein provides the attachment to our cell and then allows the membrane of the virus to fuse with our membrane, and then the RNA and the enzymes to enter our cells, just like SARS-CoV-2 does. However, they have been curious about the fusion protein, that does it help with the infectivity? We know that it will help with the fusion, and I'll explain that a little later. But does this help with the infectivity? And they found out that if the attachment protein is removed from this virus, then in the 50% of the cases, the fusion protein alone is sufficient for infectivity. Similarly, they also saw that if fusion protein is knocked out and just the attachment protein or G protein is left, then the infectivity of the virus reduces. That means fusion protein helps with the attachment as well. We know that it connects with the glycosaminoglycans, or the carbohydrates on the surface of the protein, the attachment protein. The fusion protein attaches with the CXCR3 proteins. However, we are actually not very clear how these attachments and infection works. In addition to that, there are other proteins, for example, small hydrophobic protein. Then within the virus itself, there is a matrix protein. Then the RNA is packaged with the nucleocapsid proteins, just like SARS-CoV-2. In addition, there is a RNA polymerase present. There is phosphoproteins present as well, phosphoprotein A and B and other enzymes. So this is the general structure. Because it is an enveloped virus, it has similar behavior, that when it has to enter our cell, it has to fuse. The membrane of this virus has to fuse with our cell's membrane, and then the RNA and the enzymes will go into the cell, make more viruses, and then those viruses would come out. Another important thing, why do we call it syncytial virus? Syncytia means a big unit. So why do we call it syncytial virus? The reason is this virus can cause our infected cells. This is such an interesting thing that it does. So let me once again go back to so what it does is, imagine this is a virus. When the virus infects our cell, mostly the respiratory cells, right? So upper respiratory cells, that is fine, but when it infects the lower respiratory tract cells, that is when it becomes more dangerous. But anyways, when it infects the epithelium is a surface cells. When it infects the epithelium of the respiratory system, the cells, they start swelling. Why do they start swelling? Because the virus is inside replicating. In addition to that, the virus causes the fusion protein, that is viral protein, to start appearing on the surface of our cell. So imagine if I was a cell, human cell, respiratory system epithelial cell, and the virus infected me, then on my surface, I would start developing fusion proteins, F proteins. But that's not all. The F proteins of the cells, they start binding to the neighboring cells, and they fuse them, they get welded together. And then those cells start fusing together, making a larger cell. That larger multinucleated cell, why is it multinucleated? Because many cells fused together to make one big cell. So that multinucleated cell is called a syncytium. And because of that big blobby cell that is formed, that cell gets expelled from where it was present. Just like a popcorn, it pops out of its queue. It pops out of the surface because it has swollen, because it has become bigger. What a weird mechanism that this virus uses. And the result of that is that when that cell, which has now sloughed off, as we say that in medicine, the cell that got sloughed off and is now fallen in the respiratory system airway, there the infection would occur and inflammation would occur and the obstruction would occur because the cells are now falling in the airway. And now think about very tiny children, small children, especially the premature babies. Their airways are already very small. And then if we plug them by these sloughing off cell, popping cells, and the inflammatory cells, and the congestion by the fluids, that can become bronchiolitis. Bronchiolitis means the inflammation of the small airways, and even pulmonary pneumonia, which can cause severe infection in the patient, causing them to be hospitalized or even needing to be ventilated. So this is the interesting mechanism that it does with the fusion protein. So fusion protein, please remember, in some part of the literature, you would see that it will say it allows the virus to fuse with a cell. And then you would see in some other literature that it will say that the fusion protein allows the cells, infected cells, to fuse with each other. It actually does both. Okay, so continuing. Some clinical, today we'll have less diagrams and more notes, some clinical notes. It has a very short-lived immunity. That's very interesting. So because of this, it causes reinfection. And because of this, sometimes even when the previous antibodies are still present, new infection will occur. So let me actually quickly show you that. So here, if you see high levels of neutralizing antibody, this is Javet's microbiology, that is maternally transmitted and present during the first several months of life, are believed to be critical in protective immunity against lower respiratory tract illness. Severe respiratory syncytial disease begins to occur in infants at 2 to 4 months of age when maternal antibody levels are falling. However, primary infection and reinfection can occur in the presence of viral antibodies. So the viral antibodies are present, and even then reinfection can occur. The reason, this virus suppresses production of interferons. Number one. Number two, they have seen that patients who have, and I think I was not able to share that screen. So 1 second, I'm going to share it. So I've been using OBS because of my software changes, and apologies. So here, this is Javet's. I was reading this paragraph over here. So back to the discussion. Interestingly, the cytotoxic pathway, T helper 1 pathway, when that is activated, then this virus has a milder disease. However, the severe disease is associated with increased IgE levels. So it seems like if the immune pathway goes towards T helper 2 pathway, the humoral response, then the protection is less. And not only the protection is less, the severity is more. And I think that has something to do with the IgEs and the antibodies. Why? Because when they created the neutralized or inactivated virus vaccine, which caused the antibody production, that antibody production actually created enhanced disease. So cytotoxic pathway is more important. And so once again, let me switch my screen to show you that reference as well. So if you see here, down here, cellular immunity is important in recovery from infection. Then if you see here, this is the lower yellow part I'm reading. An association has been noted between virus-specific IgE antibody and severity of disease. Viral secretory IgE antibodies have been correlated with occurrences of bronchiolitis. And bronchiolitis is a severe form of the lower respiratory tract infection, which becomes severe in children. So, very interesting that the virus is better managed with the cytotoxic pathway and causes more severe disease with the humoral pathway. That is why the vaccines aren't working very well. Okay, so clinical parts: short lived immunity, recurrent infection, no vaccine so far, causes infection from 2 months onwards, mostly in children. What is the reason? The reason is that mother is usually, so we are usually infected in the community setting by this virus. In adults, it doesn't really cause lots of symptoms or a problem. It seems like common cold and done. In children, what happens is that mother secretes the IgEs and IgA, especially IgA, in milk, and then mother has given IgG through placenta before birth. So when the child is born, they actually have maternal antibodies to fight this virus. But those maternal antibodies start waning after 2 months to 4 months. That is the time when the child is most at risk of developing this infection. But generally, healthy children can handle this. Now, here is a very interesting thing. Do you know why the vaccine is not becoming successful? Not only that, vaccines are causing humoral infection, or sorry, humoral arm of the immune system response. The other problem is that to give this vaccine for these children, one had to inject them somewhere before 2 months. So that means near birth. But the problem is, near birth, the child's immune system hasn't yet matured enough to start making their antibodies and start processing antigens. Not only that, mother's antibodies may be running around in the child's blood, which is a good thing. But when you give a vaccine, mother's antibodies will attack the vaccine and clear it out. So the child will not have a chance to look at the antigen and make or get training to make the antibodies. So there are multiple factors why the vaccines for these viruses have been failing. Okay, continuing. It has a seasonality. Normally it starts by fall and peaks in January, February, US seasons, and then by spring it has gone away. This time, they're calling it a triple demic. That is, there is SARS-CoV-2 infection going on, there is flu infections going on, and there is the RSV infections going on. And they're saying that it is possible that the epidemiology has changed because of SARS-CoV-2. For example, in 2020 until 2021, the RSV infections actually almost disappeared because of the lockdowns. Then in 2021, August, those infections started, RSV infections started reappearing. They say because of people starting to get out. And now they are more in swing because they're saying children are also going out to the schools and mixing in the community. And this has to happen. The answer is not going to be let's have more lockdowns, because you cannot continue to cause the immune system to stay idle. Eventually, the children have to go and be exposed to it. So that is what is the general consensus or commentary. However, I think there is an additional point that many are missing, and that is when there were lockdowns, masks, other protection mechanisms that caused mothers to also have less exposure to RSV. That allowed pregnant mothers to not offer a lot of IgG to their children. And so the children born to mothers during the lockdown time, not only these children's immune system stayed unaware or naive about these infections, but mothers also did not offer a lot of protection through their IgGs or their IgA in the milk. So there is a maternal factor as well. Okay, so most of the cases, RSV causes upper respiratory tract infection. In some premature children, some folks with immunocompromise, it can go downwards to the lower respiratory tract infection and cause the lower respiratory tract infections, which can become severe. Now, interestingly, it's R naught. The spread is from 8 to 25. One person can make 8 to 25 people sick with it. Fortunate for us that it is not very severe. And the transmission is respiratory, so respiratory droplets. It can actually survive on our skin. For example, somebody touched their nose, can survive on the skin for 20-30 minutes. It can survive on fomites, so the harder surfaces, for 3-4 hours or more. Incubation time is 3 to 5 days, and the shedding of the virus starts 1 or 2 days before the symptoms that appear. Now the patient stays contagious for 3 to 8 days, they keep shedding. But if the patient are premature baby or they are immunocompromised, then even 4 weeks after the symptoms, patient may still be shedding the virus. And I have already discussed this, that cytotoxic pathway, T helper 1 pathway, seems to be a better response of the body for this virus than the humoral pathway. Now, infections in children, fairly self-limited. What happens is upper respiratory tract infections, for example, runny nose and nasal congestion, cough, low-grade fever, inflammation of the nasal mucosa, so swelling of the inside of the nose, called rhinitis, and the swelling of the throat, called pharyngitis. Then conjunctivitis, of the redness of the eyes, can occur as well. So see, these all look like SARS-CoV-2 as well. But remember, SARS-CoV-2 in children can cause GIT issues more often, and RSV never causes GIT issues. Now, this is possible that there are two infections together, but generally RSV does not cause GIT issues. SARS-CoV-2 in children cause more GIT issues. Okay, so 15 to 50% of the children can develop severe disease. And how do you, if you have a child, how do you know that they may be in need of help? If their respiratory rate increases, so they start breathing faster, or if they start using abdomen for the respiration, or if you see their intercostal muscles, that is the muscles between the ribs, these are pulled inwards as well, that means the child is struggling to breathe. Wheezing could also be there. Croup could also be there. So that barking type sound because of the involvement of the upper airways, the trachea. Dehydration can occur because one of the symptoms in children, or the outcome of the infections, is that child becomes or loses appetite. So they stop feeding, they stop drinking milk, they stop taking water. So dehydration is a very common problem. So one has to make sure that they are hydrating. Now, the at-risk community is small children, usually lesser than 2 months, premature children, even up to a year, some even up to 24 months, and then immunocompromised adults. I've already discussed that why it is called syncytial virus, because it fuses the cell. So far, there is no vaccine. And we talked about it, that inactivated virus vaccine resulted, when they tried to make it, resulted in vaccine-associated enhanced respiratory disease, or VERD. 80% of the children were hospitalized who were vaccinated by this infection, compared to natural infection, only 5% of the children. And 2 children died in the vaccination group, so they stopped the vaccine. This is the drug I was having hard times talking or saying it. So pelivizumab or pelivizumab, monoclonal antibody. So what it does is this palivizumab, it binds with the fusion protein of the virus and prevents the viral attachment to our cell and enter the cells. Plus, it also prevents the fusion of multiple infected cells to make those big giant cells. So that not only reduces inflammation, it also reduces the viral replication because virus has less cells to go in and replicate. And then how do you see the difference? RSV, usually upper respiratory tract infection. Flu or SARS-CoV-2 can also cause GIT symptoms. Now, SARS-CoV-2, it's not very common, but SARS-CoV-2 can also cause anosmia, which flu cannot. Now, if the child has flu, then oseltamivir is given, and then palivizumab for this one. And SARS-CoV-2 I left empty because we know there isn't a clear answer. With this, now I want to read one last thing, and that is the American, let me go here. So I want to read the updated guide. So here the American Academy of Pediatrics and who should get the palivizumab. This is actually 2014, but if you go to their current update, which is 8/26/2022, they also then link back to that 2014. So since 2014, this has been their advice. So what is their advice? Let's read that. So the whole document is interesting. I'm just going to go to their summary. So this is the summary. So what they say is, in the first year of life, palivizumab prophylaxis is recommended for infants born before 29 weeks from 0 days gestation, so premature infants. Then palivizumab prophylaxis is not recommended for otherwise healthy infants born at or after 29 weeks. In the first year of life, palivizumab prophylaxis is recommended for preterm infants with chronic lung disease of prematurity. So the children who are born premature, they might end up with the lung disease. So that is defined as birth at lesser than 32 weeks. Clinically, many administer palivizumab prophylaxis in the first year of life to certain infants of hemodynamically significant heart disease, a heart disease that causes the blood pressure changes or hemodynamic issues. Clinicians may administer up to maximum of 5 monthly doses of palivizumab, 15 milligram per kilogram per dose, during the RSV season to infants who qualify for prophylaxis. Then palivizumab prophylaxis is not recommended in the second year of life, except for children who required at least 28 days of supplemental oxygen after birth and who continue to require medical intervention, for example, supplemental oxygen or chronic corticosteroids or diuretic therapy. Monthly prophylaxis should be discontinued in any child who experiences a breakthrough RSV hospitalization. Children with pulmonary abnormality or neuromuscular disease that impairs the ability to clear secretions from the upper airway may be considered for prophylaxis. Children younger than 24 months who will be profoundly immunocompromised during the RSV season may be considered for prophylaxis. Doug is saying, why is Dr. Bean medical in the top right? So because this whole system, my other software is not working with this new tablet. And so I have to change my software. And when I'm changing the software, I have to use the OBS. And when I'm using the OBS, it doesn't have the same behavior as the StreamYard. So my apologies. I'm up here. Okay. So insufficient data. I hope I have spoken about children younger than 24 months who will be profoundly immunocompromised during the RSV season may be considered for prophylaxis. Insufficient data are available to recommend palivizumab prophylaxis for children with cystic fibrosis or Down syndrome. The burden of RSV disease and cost associated with transport from remote locations may result in a broader use of palivizumab for RSV prevention in Alaska Native population. And then palivizumab prophylaxis is not recommended for prevention of healthcare associated RSV disease. Martin says, I like him in the top right corner. Okay, excellent. Hello. So this is it. This is the discussion. I wanted to make sure that we can look at these guidelines. Then read this article as well, where they are discussing that there are cases where hospitals have their beds that are filled. In some cases, for example, Ohio or Texas, children have been waiting from anywhere 8 hours to 36 hours, and then the abandoning of the hospital, so checking into the emergency, waiting, and then not getting their turn yet and leaving to go to another hospital, that has been increasing as well. So this is the discussion. Once again, more care for those who are immunocompromised or who were born premature or who had the chronic lung disease of prematurity. Younger, healthy children, healthy meaning the ones who were born healthy or were born term, they have less risk, but still infection and reinfection can continue to occur. And that is I think unless the society becomes homogeneous again with these infections and we all start getting reinfected, till that time such outbreaks will continue to happen. So Texas says they had, John says they did not have mask mandates, but maybe the lockdown. So these are all speculations. There is actually no firm reason for why it is increasing. So these are general speculations, which are here in this article. So I'm not speculating. These are the folks in the JAMA article or other articles thinking. Schools opening is also said to be a reason that children are going back to school. Okay, so with this, thank you very much for I'm just looking at the comments. Excellent. So upper right corner it is. So as long as my other tablet is broken and I have to use Huion, I will have to be in the upper right corner. Okay, so with this, thank you very much for joining me. Please like, subscribe, and share. Tomorrow we'll have Dr. Keith Berkowitz with us, and we'll discuss how he is managing the latest cases that he is receiving, especially the long COVID cases with tachycardia and blood pressure changes. So thank you very much. There are links in the description. If you would like to support this work, you can buy access to Drbeen, or you can buy me a coffee, or you can use PayPal. And there are tons of other links in there as well. See you tomorrow. Bye for now.